Good morning, ladies and gentlemen. I will stand up so the film could film me and you can see me. But I'm not sure if I'm going to succeed. Maybe I just should stay seated. Anyway, my presentation has like a approach that is a continuity with what has been presented. So what are we talking about when we talk about the role of community or citizen monitoring of the quality of health services, of right realizations of health services? Incredibly, when I was studying medicine, I was surprised to find within healthcare delivery moments at the hospital a frequent phrase that is said usually by providers to the pregnant woman that is delivering her baby. When they shout or they claim because of the pain, I was surprised to hear, now you shout, now you are claiming, aren't you? Why you didn't shout or claim the moment you were doing it? This aggressive addressing to a woman that is in a very important moment of her life, for my surprise, was not an anecdotal case. I have heard this phrase in many places, many hospitals of Peru, and now that I'm linked with other networks, I know that this is also happening in many countries, unfortunately, in public services, also in private services. So, people need to say why they are not going to health facilities. Why, even though important efforts of many ministries of health trying to address the barriers of access to healthcare, equality and rights respect is still getting behind. And as I was saying some days before, in this new gospel of universal health coverage, all the attention seems to be posed on coverage as mostly registry of people inserted in a system and financial mechanisms to support their access. But the idea of effective quality health care is not necessarily there, and if it is there, there are no indicators, there are no criteria as strong as the others, financial and registry, as we would like to see. So people has a role, and people needs to have a voice to say why, no? As it said here, still rural, although many efforts that have been made among different governments in Peru, still rural indigenous pregnant women, for example, reject going to health facilities due to lack of knowledge or respect for their cultural beliefs, practices, or just because there are frequent episodes of women's disrespect, abuse, as Abai was saying, underestimation of women's voice and rights, and also under-the-table payments and some corruption at the local level. So we don't want to generalize, but these are things that happen when the system doesn't have enough eyes and capacity to oversee its responsiveness to people's health and needs. And that's not only a rural issue. At urban places, teaching hospitals have many times these cases of good medical doctors that are teaching obstetrics, for example, but that have wide number of students that have to practice, no? And unfortunately, because the doctors, the teachers, sometimes they are running out of time, or they want just to be other place and not fulfill the 2 hours of practice. They just choose 1 or 2 pregnant women at the public facilities just to make the 80 students to practice their obstetrics, no? And that's something that we can't deny. We see this, as well as we see an increased number of cesareans, C-sections, just for the practice of the medical students. So there are some still invisibilities that we need to address, and that needed to be addressed with real cases. So we have made alliances with different actors in Peru. One of them is Foro Salud, which is the widest civil society network. It gathers like 100 organizations working on health in Peru, and many volunteers. It's a volunteer-based network. We have made alliances with Ombudsman Office at the local levels to work about health rights. And there have been some advances, no? Just to mention some of them. After like 6 years of work, there has been enacted a law on health services users' rights. there have been also efforts to balance the representativeness of people and citizens in the invited spaces that are, the few invited spaces that are created with the government. And we have the experience of the citizen monitoring on quality of health services and have been extended to social programs as well. So I'm not going to get into the detail of this. I hope the case study is going to be published and also we hope it could be in the web of MSP, but also it's on the web of COPASA network. Just to mention that the process is not just a checking list of what is happening at the health facilities, a process that we consider create conditions for empowerment somehow. Women are elected from the same communities and they are part of a capacity building process that works in the language that they speak, with methodologies that are participatory, and constructing the concept of the right to health. Because, for example, in Quechua, the word rights doesn't exist, and the general concept doesn't exist. Many times, much along historical years, indigenous population has taken the healthcare like a favor or a concession of the state and not a right. No? So there's a process of capacity building. They go to the facilities, speak with the women in Quechua or Aymara, which is their natural language. They observe amongst the criteria that they themselves have selected, and after that, they gather the information after like 1 month of visiting. They gather again after visiting different health facilities, and they analyze which have been the most frequent cases that they have found to prepare an agenda of dialogue with the public servers and the authorities. This second moment of analyzing what they have found and preparing the agenda is also an empowerment, enabling process, and also the dialogue itself that they have with the authorities and the agreements that they arrive to is an important moment. And of course the monitoring of evaluation that is made by themselves. No? So in general, results are similar to what has been presented. We think that it's important to identify on the same point of views which are the practices and cases that are deterring women and other people from utilizing services, such as an availability of services at most needed daytimes, because they come from very far. They come from very far to the health facility. Many times they arrive at afternoon, and then in afternoon the health facility is closed. And there are also cases of denial of their entitlements under what is called in Peru the integral health insurance system that makes their health care economic financing for free for the poor people, but sometimes people are charged on things that they should not be. So that those things also happen, no? Charging for medicine and services that were meant to be free. No? A second result is that it has opened the space for creating a dialogue, a systematic periodic dialogue with the health providers and health authorities, which didn't exist. Surprisingly, we are in a democracy in Peru, but democracy is just electing people each 5 years for many citizens. There are no spaces for dialogue, no accountability mechanism, strong accountability mechanism, and this is the first local process that promotes accountability from health providers. There have been commitments and actions to improve health care in terms of opportunity, the way people are treated, the information that they have. I can't enter in all the details, attending people's in their own language, respecting the culture and what they expect from the health facility. I like a lot this quote from one of the citizen monitors. When I introduced myself with the hospital doctor, he asked me, "What is all this quality surveillance thing about? Here we are working hard, you should be doing the same instead of losing your time. Or would you like me going into your home and watching all what you make there?" I told him, "Doctor, we are vigilantes, that's the name in Spanish. It's not Batman, but the vigilantes. And we have been trained for this activity. We know the laws. You cannot go to my home because my house is private, but I can come to the hospital because this is a public service, and here are my credentials, because they are accredited by the Ombudsman Office." So it has contributed to the empowerment of women community leaders. It has contributed with medical practitioners and health authorities to be more accountable to people's needs, has improved obstetric care and child care, and in the case study there are the details of the numbers of a 30% increase of the demand of health services and a 40% increase on the health health delivery of babies in a vertical position, which is something demanded by women themselves. But in general, this has increased general awareness of rights amongst health authorities and within patients and local communities. It has even contributed, after a process of advocacy that has been driven by CARE and the Ombudsman, to have now national guidelines for promoting citizen monitoring of health quality in Peru. However, the road is always not so easy. You always find challenges in the health system that I will mention later. So in terms of lessons learned, we subscribe that improving the health of the poor and marginalized in countries with deep and just inequalities cannot be achieved solely through technical interventions or funding, more funding. We think that significant but mostly sustainable change will only happen if the poor and their leaders have a much greater involvement in shaping policies, practices, and ensuring what is agreed is actually happening. Because it's an ongoing process. Many times you change of authority and you have to begin again with all what means rights, participation, governance, etc. The importance of partnership and alliances with public and non-public actors, for example, civil society organizations on the side of non-public, public ombudsman office, also the managers of the integral health insurance system are now very interested in these initiatives. The importance of accountability based on dialogue and governance is strengthening, not only name and shame, but building mutual understanding, confidence and credibility on both sides. But most important for what we were talking in this conference is the need that, and we have walked this walk, the need to go beyond local citizen monitoring to a multi-level vertical integration to influence subnational and national policies towards the right to health. So it can't stay only, we have data, as it was being said, that could inform what is happening in these health sector reform processes and proposals. We have data that has identified different health system challenges to rights to health realization, like the absence of standards for quality and performance, the same with local management at the local level in the health system, the issue of discrimination, not only at the point of use, but also when in the moment that you make the decisions for allocating resources or allocating health personnel, authorities at the regional level who are in charge of the health care of the people at the regions, which is the subnational level, many times have more political based interest when they take the decision of allocation of resources, equal votes, more than the need and the right of the people. A lot of human resources policies issues, like what I call medical schizophrenia. This is the medical doctor, not only the doctor, that in the morning in the public facility is sometimes mean with the people, but in the afternoon is a treaty of quality, his private practice. So the issue of incentives for good performance of health personnel, but also the lack of conditions of work of the health personnel. With that, we have also recognized that at the rural level. There's a lot of problems in terms of salaries, supplies, career path, etc. The lack of accountability culture, recognizing that there are not just power relations between the people of the community, the indigenous people and the health provider, and of course the different upper levels of the health system. This is a very big problem. And so also we have identified that unfortunately this is a reflect of how our most influential society thinks. No, when we sometimes have addressed this to the media, we have found reporters that are more on the side of what we could say the invisibility of the people than recognizing these issues. So I will advance. What happens in the facilities, what happens and is raised by citizen monitoring could be used to address the gaps of the health system. Here we are talking about the health sector reform. This is the Minister of Health. Should not only be a salary-based reform. There are more things like quality, participation, social determinants, and increase of the budgeting. Here is about, this is our national media newspapers. We are talking about the new cancer program of the government, and here very little is a mention that it says, the sustainable thing is to strengthen the public service instead of privatizing the services, which was the proposal of the government for this first period of this program, just to contract private providers with like 20-something years contract for making things that the public service could do. Or just addressing directly, there are issues that are not covered by the reform, and here we're talking about social determinants of health, quality of health facilities, addressing cultural issues, citizen monitoring, the absence of a participatory process for the design of the health sector reform proposal here in Peru. Some people will say that this is not me. Actually, this is me. They told me, it was a radio, it was a call interview, so they told me, just send me any picture you have. And the only picture that I have at that moment was my wedding picture, because I promised my wife that I was going to lose weight for my wedding. I didn't say for all my marriage, I only say for the wedding, and I did it, so that's me. Anyway, so when it comes to inform universal health coverage, no, and thinking about what happened with the Millennium Development Goals, and that we are very near to get new agreements, important agreements in post-2015, how do we go from mothers and children, which are important, to universal rights? No? First, addressing inequalities, and I think I don't need to extend here. The national averages hide a lot of unjust differences within the countries. Second, addressing fragmentation. So it's not only maternal health. Women are just not meant to be mothers. So we need to focus on women, even focusing on women in integrality. We need to address gender-based violence. We need to talk about abortion and the damage that it causes to our countries. LGBT rights. We need to address social determinants of health. It's always mentioned, but its absence in all the frameworks that are supposed to monitor what happens with the new gospel of universal health coverage. We need to make the case of going beyond this metrics obsession that has been caused by the Millennium Development Goals, where donors are focused on value for money metrics, which puts pressure to our own monitoring and evaluation and advocacy work, because how do we define impact and results in a specific period of time when we are talking about complex long-run processes where an actor-based oriented approach with not necessarily predictable results? It's a challenge, and here we have listened a lot of alternatives in terms of ethnography that could make good evidence to inform what is happening in the health systems, not only the health system, also the water system, etc. Because now we are like facing a phenomenon like the pharmaceutical company when they come to the doctors and they bring apparently good-made research that just justify the appearance of a new medicine. We are not in a moment of evidence-based policy. We are in a moment of policy-based evidence for the interests of some groups, and we need to address that. We need to have our own evidence. To inform on the quality and responsiveness gap to people's needs and expectations. I raised culture, but we need to decompress what do we mean with coverage, universal health coverage, what coverage actually means. Because we are facing, in some countries, the issue of universal health coverage equals universal health insurance, that at the end of the day is just universal health registry. For some people, it's just like saying, you have free health care in Miami. Your problem is not going to Miami. No? Alerting health sector, the risk of health sector reforms, the issue of mission accomplished. I have already heard all this new trend of, now the problem is chronic diseases, now the problem is diabetes, cancer. Okay, that's the problem. But the task has not been accomplished. And the problem is that for some officers in their speeches, they talk like if this is the new task of the government, and that maternal health, child health has already been solved because the national averages have increased, have reduced, and that the work has been done. In Peru, we say you can't take the dress of a saint to dress another one. Work on the chronic diseases, of course, but don't leave behind the poorest of the poor, no? And also the risk of privatization. We don't think that privatization is absolutely wrong, but when we read reports like the one of Oxfam about the Lesotho hospital, when they conclude that the Lesotho Health public-private partnership, which is also the new trend, has been described as opening a new era for private sector involvement in healthcare in Africa. Instead, the Ministry of Health in one of the world's poorest and most unequal countries is locked into an 18-year contract which already consumes 51% of its budget for one hospital. Far from being cost neutral, government spending on the IFC's flagship health-public-private partnership is spiraling, drawing resources away from other urgent healthcare needs and exacerbating health inequalities across the country. I really recommend you to read this report that has just come. Addressing unjust power relation, and I will just finish with what I said in another venue that I was invited to. Governance, 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 and accountability, accountability, accountability. One of the key failings of the Millennium Development Goals has been the lack of robust mechanisms for citizen feedback and participation in monitoring progress and holding governments accountable. But who holds donors accountable? Because many times they could work for good, or many times they could work for really, really, really bad. No? So we need to have evidence, we need to come to analyzing health systems on the right basis, lenses like the Lancet 2008 report on the right to health. We need to work for our own evidence, but especially we need to make the case that without the people inside, nothing is going to function. Thank you.